So let's talk about some of the anxiety disorders here. Now, I did not change a whole lot of this lecture because really the way that I formulated this lecture a few years ago is actually consistent with the DSM-5, even though we didn't have the DSM-5 when I was writing this. Not to pat my own back, but I think not just me, but a lot of us sort of anticipated some of these changes, and I went a little cavalier and sort of designed this lecture initially to reflect that broad consensus, and indeed it wound up getting reflected in the DSM-5. So some major changes that we have, for the most part, it's just a reclassification. The diagnostic features remain largely unchanged. So the reason that we have this reclassification is that our understanding of anxiety disorders and disorders that are related to anxiety is expanding so rapidly that we can't help but reclassify these so it reflects our greater understanding about the differences and delineations between these disorders. So the diagnostic features, though they remain largely unchanged, we have reclassified these disorders to really just reflect the reorganization in our understanding, our increased understanding of these disorders. So obsessive compulsive disorder is actually now a class of itself. It's no longer recognized as an anxiety disorder. It's now recognized as its own class of disorders, and indeed, we'll see that the obsessive compulsive disorders and related disorders are actually a very heterogeneous set of disorders. PTSD and acute stress disorder are now reclassified. They're no longer under the anxiety disorders, but they are under the classification, the heading trauma and stressor-related disorders. Separation anxiety disorder used to be classified under the disorders, the heading disorders usually first diagnosed in infancy, childhood, or adolescence. Now we have taken separation anxiety disorder and reclassified it under the anxiety disorders. The reason here is because adults get separation anxiety too, and I mentioned that in the initial lecture that I had made a few years ago. Adults certainly get separation anxiety disorder. You can imagine 19-year-old, 20-year-old going off to college. They can get separation anxiety too. Homesickness is really a form of separation anxiety disorder when it's severe enough. So this just reflects that you don't have to be a kid to get separation anxiety disorder. Selective mutism is now recognized under the anxiety disorders just for the fact that patients who are selectively mute, and these tend to be children, also have a high concordance with anxiety. Now, there are some changes sort of in the features of these disorders, or at least how we recognize them. So specific phobia, that would be like arachnophobia or fear of heights. This no longer requires that the individual recognizes that their fear or anxiety is excessive or unreasonable. So that used to be one of the sort of minor criteria of these specific phobias. Now it is not required that the individual actually recognize that what they're going through is excessive or unreasonable. We've also changed the duration requirement. So it used to be that the duration requirement differed depending on whether you were dealing with a child patient or an adult patient. Now it's the same. So that's kind of nice because we don't have to remember as much. The duration requirement is 6 months or more, both for pediatric and adult patients. So for anybody, it's got to last 6 months or more. Social phobia, and I never liked that term, it is now called social anxiety disorder. And I never liked the term social phobia because these patients are not afraid of other people. They're anxious around other people. So maybe you could call it socializing phobia, but we call this now social anxiety disorder. And indeed, we've been calling it social anxiety disorder for a long time. So because I didn't make a whole lot of changes in this lecture, I'm actually just reusing the previous lecture and just prefacing this by telling you what some of these changes are, because so much of the previous lecture just is relevant for now and really hasn't changed much other than these changes in classifications. You will see that I still call it social phobia in this lecture, just be aware that it's now officially called social anxiety disorder. We've been calling it social anxiety disorder for a long time informally, but now it is the formal term for what we used to call social phobia. And I don't like changes personally, especially all these changes to the DSM with the DSM-5. It's a lot of new stuff to just have to commit to memory, but this is one change that I really like because I think this is a much more accurate term for what these patients are experiencing. Like the specific phobias, these patients don't need to recognize that the fear is excessive or unreasonable, but because social anxiety disorder is such a pain in the butt for people and it gets in the way of their social life, most of these patients will recognize that the fear is excessive or unreasonable. And in fact, understanding that the fear is excessive or unreasonable is really what helps delineate this out from some of the personality disorders in which the patient doesn't get involved in social situations because they have no desire to. So even though this is now the patient doesn't need to recognize that the fear is excessive or unreasonable, in the vast majority of patients with social anxiety disorder, they will recognize that it's excessive or unreasonable. And then also here, the duration, 6 months, is now uniform among all ages. Panic disorder and agoraphobia are no longer technically linked. However, the diagnostic criteria remain the same. So whereas in the DSM-4, we had panic disorder with agoraphobia, panic disorder without agoraphobia, and agoraphobia without panic disorder, so you couldn't really get one without referring to the other at least. Now they're just nice, clean, two separate diagnoses. You can have both, you can have one without the other, but we no longer refer to it as panic disorder with or without agoraphobia or agoraphobia without panic disorder. We now have two separate diagnoses. Yes, you can have both of them, but they're coded as two separate diagnoses. So now it's nice and clean. It's organized much better. You can have panic disorder, fit those criteria. You can have agoraphobia, fit those criteria. But we now recognize, and it's much better organized, that you can have one or the other or both. We have changed a lot with the obsessive-compulsive disorders. As I mentioned, they're now in their own class of disorders under their own heading in the DSM-5. And it also includes some various new disorders, including hoarding disorder, which is an interesting one. If you watch some of the reality shows on TLC, you'll get an idea of hoarding disorder and what that is. I'm not going to talk about it in this lecture because, one, it's kind of self-explanatory, and two, I've never seen it ever come up on the USMLE. But the reason that this comes up under obsessive-compulsive and related disorders is pretty self-explanatory too. I mean, people with hoarding disorder have an obsession with accumulating new things, and they have a fear of getting rid of things. And their compulsion is to save things. So it really isn't a form of obsessive-compulsive disorder, but it is its own disorder, hoarding disorder. It falls under the classification of obsessive-compulsive and related disorders. Excoriation disorder is now classified and recognized under the obsessive-compulsive and related disorders. And then, of course, we recognize that obsessive-compulsive disorders can be caused by substances and medications, and it can also be related to other medical conditions. Trichotillomania, which is the hair-pulling disorder, has been moved and recategorized. It used to be under the impulse control disorders, not elsewhere classified, and now it is considered under the obsessive-compulsive and related disorder. Again, patients with trichotillomania tend to have this obsession with pulling their hair out, and the compulsion is then relieved when they do that. So a lot of these things, like I said, we kind of anticipated, and it's reflected in the lecture. Some general principles about anxiety disorders. So, what is anxiety? Anxiety is an ego-dystonic fear or concern, and I suppose all fear would be ego-dystonic,
that's out of proportion to the situation. So it's your fight or flight symptoms. If you're being chased by a bear and you have fight or flight symptoms, that's not anxiety. That's an appropriate response to your situation. But if you see a harmless spider, or you're worried about going out for a dance and you start trembling and you have nausea and you're sweating and you have fight or flight symptoms, that is anxiety. So what are your fight or flight symptoms? They're nausea, trembling, sweating, ruminating worry, hypervigilance, difficulty swallowing, palpitations. So you need to rule out substance use in any of these patients. Any patient, especially that presents to the ED with anxiety disorder. So if the patient has symptoms of anxiety and they present to the clinic, you don't need to rule out substance use. But if they are presenting to the emergency department with really anxious fight or flight symptoms, definitely get a urine tox screen. You always want to rule out medical or substance causes before diagnosing psychiatric illnesses. You also want to rule out medical disorders. Now, this one's very, 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 very specific to anxiety disorders. Myocardial infarction can present with anxiety or panic symptoms as the only symptom. And so in any patient who's presenting with acute anxiety, you need to get an EKG. You have to rule out myocardial infarction. That's a big one. So anytime a patient has anxiety symptoms and they say, what is the next step, and an EKG hasn't been done, get one. Get an EKG. Also, hyperthyroidism and hypoglycemia should be ruled out as well. And that can be found on a TSH and a CMP respectively. Some theory of why we have anxiety. The raphe nuclei of the brainstem is mediated by serotonin, and this is really our rest center. So what we think is that there's an imbalance between the raphe nuclei and the locus ceruleans, which is our source of awareness. It's our arousal. That's in the pons. And remember that the locus ceruleans is mediated by norepinephrine. So very important to keep in mind that there's always going to be a physical explanation for any psychiatric disorder, even if we don't see it. But what our idea is that in anxiety disorders, there's an imbalance between the interplay between the raphe nuclei and the locus ceruleans, which is mediated by serotonin and norepinephrine. And so this is why we use SSRIs to treat these patients with anxiety. SSRIs aren't just for depression. We also use psychotherapy quite frequently. So these are the anxiety disorders we're going to talk about. So before we talk about panic disorder, let's talk about what a panic attack is. And remember that a panic attack is a symptom. It is not a diagnosis. So a panic attack is a random, sudden onset of displeasing psychologic and physiologic symptoms. It's a random, sudden onset of symptoms that we said relate to anxiety, the fight or flight symptoms. It's all of a sudden you're sitting in a coffee shop and you get the fight or flight response. It comes out of nowhere. You might be driving and it comes out of nowhere. There's no trigger. You don't know what caused it. That is a panic attack. If you're sitting on a bus and all of a sudden you feel like somebody's going to jump out and kill you, your heart starts racing, you can't breathe, you feel palpitation, you're sweating, you feel out of your body, and there's no reason, that is a panic attack. And so the hallmark of a panic attack is that there's no apparent cause that you can identify. They tend to last minutes to hours, and they usually peak around 10 minutes. So panic disorder is when you have a panic attack and a month has gone by where you have worried about having another panic attack, or you've adjusted your behavior and avoided certain things because you're worried about that panic attack. When a panic attack has interfered with your life for at least a month, that is panic disorder. Usually they present as a panic attack in the ED, but when you delve into the history, you find out that this patient has panic disorder because it's been going on for more than a month and they've been having these panic attacks and these behavioral adjustments. Always rule out a myocardial infarction. As mentioned, when a patient presents with symptoms related to panic, you've got to rule out a myocardial infarction because that can be the only presenting sign, especially in women. Always rule out medical conditions. What can cause symptoms similar to panic? Hyperthyroidism and hypoglycemia. All you need to do is get those labs. So really, panic disorder is a diagnosis of exclusion because there's no apparent cause behind the panic symptoms. Management for panic disorder is benzodiazepines for acute care. So to get rid of the panic symptoms, you can use benzodiazepines like Ativan or Xanax. And then SSRIs and psychotherapy are used on the long term to prevent the panic attacks from coming back and to help these people deal with their problems. Panic disorder with agoraphobia is really just panic disorder that we mentioned, but this panic disorder has affected this patient so much that they are afraid to be somewhere in public that they might not be able to get to a safe place in case they have their panic attack. So they avoid leaving home. They don't go to the grocery store. They might not go to work. They avoid leaving home so much that it's impacted their quality of life. And so we're going to manage these patients the same way that we manage panic disorder, but these patients are going to need a much more intense psychotherapy because of how much their quality of life has been restricted. Okay, so phobias. There's something to know about phobias, and that is that it's triggered by an object or a situation. So every time I see a clown, I get anxiety. Every time I see a spider, I get anxiety. Every time I go out in public and have to talk to people, or give a speech, or perform on stage, or go into a public restroom, I get anxiety. That is a phobia. You know what causes it. It's not like panic, or like a panic attack where it just comes out of the blue. There's a specific trigger, and you know what it is. So a specific phobia is a fear of an object or a situation. Spiders, heights, flying, clowns. It's the object or situation that is hallmark because you know what causes it. A social phobia is similar to a specific phobia in that you know what causes it, but the difference is that it's a social situation where an embarrassment might occur. And what you're afraid of is not the social situation, but you're afraid of the actual embarrassment. So you're afraid of public restrooms. It's not because you're afraid of the restroom or the germs in there or the people in there. You're afraid of being embarrassed in there. Or you're afraid of socializing. Not because you're afraid of people, not because you're afraid of making friends, but because you're afraid that you might say something wrong and you'll get embarrassed and it's just not worth it. Okay, so it's the fear of the embarrassment that's hallmark to the social phobia that differentiates it from the specific phobia. So how do we diagnose these? It's all clinical. How do we manage these? Well, a specific phobia, because we know what it is, we can expose people to it and we can sort of gradate them into their fear. So, for instance, if it's a height or if it's a spider, we might show them a picture of a spider first. They get their anxiety symptoms, we talk them down from it, they realize it's okay, and then they're okay with seeing a picture of a spider. Then we show them a spider in a jar, do the same thing. And we show them a spider in a room, do the same thing. Then we show them a spider walking up their arm. The same thing all the way until their fear is gone. You can also use benzodiazepines in acute situations, and these are good for when the patient knows that they're going to be encountering the specific phobia and it's only going to be for a set amount of time. So that's like flying. You can use benzodiazepines for that. For social phobias, we like to use SSRIs because this is a more chronic issue. You're constantly going to be in social situations. And group therapy, most obviously, because what do you have to do in a group? You have to socialize, and so that helps these patients. Short-term beta blockers are good for when the actual symptoms of the social phobia will interfere with what you're supposed to do. So for instance, if you have to speak publicly, if you get tremulous and you get short of breath, it's going to be very difficult for you to speak in public. If you get tremulous and you have to play a violin or a piano in public, you're going to have a hard time playing the piano or the violin. So we like to give these patients beta blockers to mask their fear. It's not going to dispel their psychological fear, but it'll at least mask the physiological signs and help them perform. Generalized anxiety disorder is even more severe because this is people who are afraid of everything. It's not necessarily being afraid of things, but they worry. They worry about everything. They worry about things that we can't avoid, things that you have to encounter every day. The possibility of death, your finances, your health, your family problems, your friendship problems, little things that come up. Problems at work. These people are always afraid they're going to get fired, they're going to get cancer, their son or their daughter is going to get into some kind of trouble, they're going to lose their friends, they're going to die. That's what these people ruminate over every day, and it gets in the way of their life, and they get anxiety. They get anxious, and they're restless, and they can't sleep, and they get irritable because they can't sleep, and it's an ongoing problem for them. So the diagnosis for this is clinical, and these patients are going to be very difficult to treat. We use SSRIs in these patients, and it's going to be on a long-term basis. You can use buspirone in these patients, but it's a second-line agent. You can use it in addition to the SSRI or as a replacement drug. Obsessive-compulsive disorder is even more different because these patients have strange, irrational urges that create symptoms of anxiety that can only be resolved by a certain compulsion. So let's talk about what the difference between an urge and an obsession and a compulsion is. An obsession is something that worries you. So for instance, germs not being organized, the door not being locked outside. So if you're worried about your outside door being locked, what are you going to, and it makes you anxious, what are you going to do? You're going to go check it. If you're worried about having germs on your hand, what are you going to do? You're going to go wash your hands. Okay? That checking and that hand washing, those are the compulsions. Why are they compulsions? Because they relieve your anxiety. And so you're going to do it because you feel better after you do it. But then you're going to go back, and then the obsession's going to come back. And then you're going to do your compulsion again, and it goes on and on and on and on. These patients do not like this. Okay, it's ego dystonic. When these patients do the compulsion, it relieves their anxiety. But when you ask the patient, do you feel really good about this? They're going to say, no, I really wish I could get over this. So the differential, most importantly, includes impulse control disorder. And this is different because impulse control disorder is going to be something like kleptomania or like pyromania. Those patients, they're going to have an impulse to do something, like set a fire or steal something. But when you ask these patients what the goal of what they're doing is, yes, they'll have anxiety to do what they want to do, but after they do it, it's a thrill for them. They feel great after they steal something. They feel a high after they set a fire. So it's an ego-syntonic urge because it's something that they want to do. Obsessive-compulsive personality disorder is, I only put it in the differential because it's similar in name. It's really not similar at all in symptoms, but it's important to know the difference because you can get tripped up on the names. So obsessive-compulsive personality disorder patients, these are just your perfectionists, and there's so much of a perfectionist that they just turn people off, and they're your misers, and they hoard things, and we'll talk more about personality disorders in a different section, but just know the very big difference between OCD and obsessive-compulsive personality disorder. How we manage obsessive-compulsive disorder is with SSRIs and psychotherapy. So acute stress disorder and post-traumatic stress disorder are two peas in the same pod. They are really the same symptoms, they're just different duration. So what's important here, a lot of A lot of people, when they think about post-traumatic stress disorder, they like to stress the threatening event. That's not so much important because PTSD or acute stress disorder can be caused by lots of different things. And threatening doesn't always mean it's physically threatening. It's really anything that's threatening to our psychological stability. And all of us have different levels of psychological stability. So for some of us, something like a breakup or a loss of our job, getting fired, can be severely threatening to our psychological stability. Whereas others, really the only thing that's threatening to our psychological stability is something as problematic as being in war or being in a place where there's a shooting. It all depends on the person. So a threatening event, think of as anything problematic for the person's psychological stability. So because it's that broad, what we really need to focus on here is the symptoms. And that is really what sets PTSD and acute stress disorder apart from the other anxiety disorders. And that's flashbacks and nightmares, anxiety, and avoidance, especially the flashbacks and nightmares. This is pervasive. This is really problematic for these patients. So, like I said, less than 1 month, it's going to be acute stress disorder. More than 1 month, it's going to be post-traumatic stress disorder. The diagnosis here is clinical. We like to use SSRIs and group therapy. The group therapy is really good because a lot of patients with post-traumatic stress disorder and acute stress disorder have what's known as survivor guilt. And that's, they feel, especially if it's, and this is really limited to like war or being in a place where acts of violence occurred, they feel guilty because they survived and other people didn't. So going to group therapy can help them talk about that and may help them come to some resolution. Benzodiazepines are really good for acute symptoms, especially if they're having flashbacks and they need something acutely to help them with their symptoms. Definitely watch for both increased risk of suicide and, of course, depressive symptoms, which may become major depressive disorder. Of course, if they have more than 5 SIGI CAPS symptoms for more than 2 weeks, you're going to diagnose major depressive disorder. It doesn't mean the patient doesn't have PTSD or acute stress disorder, but they're going to also be diagnosed with major depressive disorder. So keep an eye on that. Adjustment disorder is a little different, and it's got some similarities with PTSD in that there is a problematic event that's happened in a patient's life, a life change, something that they've gone through. But there's no flashbacks and nightmares. It's really more depressive symptoms or anxious symptoms, or what you see a lot is behavioral changes, and not good behavioral changes. Behavioral changes like they're going to stalk the person that hurt them, or they're going to start acting out in ways that are inappropriate, like they might start stealing things. Anytime you have a behavioral change or symptoms of depression or anxiety in a patient after something bad has happened, those are maladaptive symptoms. Those aren't symptoms that are going to help you adapt to the change that's happened in your life. And so what we say is that this is a disorder of your adjustment period. It's adjustment disorder. A lot of times you're going to see this in kids who, after their parents get divorced, the 9-year-old might start wetting the bed again. And that's going to be regression. Obviously, they're regressing to an earlier stage in life. And because kids don't really show depression the same way adults do, that's going to be how they manifest adjustment disorder in many cases. So look for that. We have to rule out adjustment disorder as it's a diagnosis of exclusion. So we have to rule out various different causes. Remember, if you see flashbacks and nightmares and panic symptoms and avoidance, that's going to be along the lines of PTSD and acute stress disorder. If there's more than 5 SIGI CAPS symptoms, even though adjustment disorder may have symptoms of depression, it's not major depression. If there's more than 5 of these symptoms and it's for more than 2 weeks, it's major depression, no matter what. If there's any psychotic symptoms at all, you have to diagnose these patients with a brief psychotic event or schizophreniform disorder, depending on how long it's been going on. The management is with psychotherapy and SSRIs. So just to recap, let's look at the trigger, because all of these things have a trigger or may not have a trigger, and then they all result in a reaction, and then we treat all of these. So panic disorder. What's the trigger? Nothing. There's nothing that triggers the panic attack. It comes out of nowhere. What's the reaction? These patients have panic attacks, and they're afraid of having another one. So we treat these with SSRIs and benzos. Specific phobias are triggered by a specific item or a situation, like flying. The reaction is they get anxious when they see it, and they avoid those items, and that might cause a problem, because if you're a businessman and you're afraid of flying, but you have to fly, that is going to be problematic. So the way they treat these is with exposure and cognitive behavioral therapy, and we can also use benzodiazepines in an acute situation like flying. Social phobia, they're afraid of the social situation, not so much the social situation per se, but the embarrassment that might happen in that social situation. So the reaction, anxiety, of course. They're going to get anxious in that social situation. And so what are they going to do? They're going to avoid it. And the treatment for this is SSRIs and group therapy. And beta blockers can be good to mask the symptoms of social phobia when the person needs to perform. Generalized anxiety disorder, these patients get anxious from everyday things. So they're going to always be anxious 9 hours out of the day, 24 hours out of the day. It's going to be a constant anxiety with these people. So SSRIs and psychotherapy, these patients are going to need a lot of support, because these patients are worried about so many different things that they see all the time. It's like all the specific phobias rolled into one. OCD is an irrational urge or an obsession that is the trigger. So a worry that the door is not locked, a worry that there's germs on your hands, and it causes anxiety, and that anxiety is relieved by a compulsion. But this compulsion happens so many times throughout the day, this cycle goes on so many times that it causes a problem in the patient's life, and they seek treatment. So SSRIs and psychotherapy. Remember, this is ego dystonic. These patients do not like having obsessive compulsive disorder. So SSRIs and psychotherapy. Acute stress disorder and PTSD, the trigger is a traumatizing event, which, remember, can be anything that poses a threat to the patient's psychological stability. The reaction is going to be anxiety, especially when they see things or are around things that remind them of that event. They'll have flashbacks and nightmares. They'll avoid anything that reminds them of the event. SSRIs are good for chronic therapy. Group therapy is good to help them talk about things. Benzodiazepines are great for helping to manage the symptoms of panic and the flashbacks. Adjustment disorder is a specific stressor. The reaction is going to be anxiety, depressive symptoms, shy of MDD. Behavioral disturbances like acting out, regression, especially in children, and the treatment here is also going to be with SSRIs and psychotherapy. And this is a nice little warm fuzzy moment. This is a patient with PTSD, and she has a dog. This specifically was from an article with people who were coming back from war, and it was talking about how dogs can be good for these patients to adapt back to life, especially if they have PTSD. And there is a lot of clinical research out that's showing that animal companionship is very beneficial for humans. So this is something to think about. There are lots of pets at shelters. Cats, dogs need to be adopted. If you have room in your house, definitely consider adopting one of our four-legged friends. And with that, I will see you in the next section.